Okay, welcome. This is Randy Longenecker. I am happy to welcome you to Engaging Learners in Addressing Rural Population Health. I'm Professor of Medicine, Family Medicine, and Assistant Dean Rural Underserved Programs at Ohio University, Heritage College of Osteopathic Medicine, and I'm the Associate Director for Rural Prep. I want to welcome our two presenters today, Dr. Yvonne Young and Dr. David Schmitz from North Dakota. This is a professional development webinar brought to you courtesy of Rural Prep. Rural Prep is the collaborative for rural primary care research, education, and practice. Collaborative between three medical schools and funded by a HRSA grant. Our mission is to improve and sustain rural health through community engagement and research in rural primary care health professions, education, and training, and that includes nurse practitioners, physicians, physician assistants, and other members of the healthcare team. These professional development webinars are intended for faculty development as well as the development of others, students, residents, and others who assist students, for example, in research. We meet 4 times yearly on the 4th Thursday of the months above. And I want to just note now our next event on June 28th. Today, we're very pleased to be addressing an important issue in population health. And our objectives are as follows. These are all important, but perhaps the most important objective is that we engage learners in disseminating this information about radon while they, in the same time, learn the principles of population health intervention. So hopefully that's what you will achieve through today's presentation. Following my introduction, I'll be turning the presentation over to our presenters. After they have completed their presentation, we'll then ask Dr. Davis Patterson, our project director, to initiate discussion and then open it to wider participation. Again, if you have questions at any time during the presentation or thereafter, please feel free to enter them in the chat box to the right of your screen, and we will address them then in the discussion time. Without further ado, let's get started. Dave and Yvonne.
Well, thank you, Dr. Longenecker, and welcome everyone. It's really a privilege and honor to be a part of Rural Prep, and particularly the professional development webinar we're going to discuss today. And then pass it over to Dr. Young. I'm Dr. David Schmitz. I'm a professor and the chair of the Department of Family and Community Medicine here at the University of North Dakota School of Medicine and Health Sciences. Really happy to be with you here today.
Hello, and I'm Yvonne Yank. I'm an assistant professor within the Department of Population Health also at the University of North Dakota within the School of Medicine.
And so I'll go ahead and share my screen. We'll have some PowerPoint slides for you today. And without further ado.
So we've already introduced ourselves. Of today's session is on radon. For those of you who are not familiar with radon, well, we're just going to give you a few basic facts about it. You can't see it, taste it, or smell it. It is one of the primary causes, or the second leading cause, of lung cancer in the United States. Does anyone know what the first cause is? And if you haven't guessed, it's smoking. So the EPA, maybe we do need to diminish that a little bit. So the EPA is estimating that 15% of homes in the US have unsafe radon levels, and we'll be talking about that in the next few slides. So radon is a form of ionizing radiation, and what we mean by that is that we have several different forms of radiation, power lines, cell phones, and etc., all the way up to X-rays and gamma rays. And what we mean by the ionizing radiation is that it's capable of pulling or removing electrons from atoms and causing them to be charged or ionized. And that is destructive when it comes to its ability to cause cancer. So how does radon enter your home? So it's radioactive gas, and it comes through the soil. And so if you have a home, particularly with a basement, then it creates sort of a vacuum and allows the gas to creep in through the ground and then up into your home through cracks and other holes. And particularly in the state of North Dakota, in the winter, when your windows are all closed and
it's cold in North Dakota.
It's cold. Then it acts as though much like a suction cup, where the warmth in your house sucks the gas up through the floor and into your home. So radon levels are the highest in the northern plains. You see here the state of North Dakota up in the Midwest area, where all counties are in the red, meaning that most counties, the homes in those counties test above the EPA's threshold of 4 picocuries per liter. So we measure radon in picocuries per liter, and what does this mean? Well, 1 picocurie per liter is the equivalent of smoking 2.5 cigarettes a day. So Nebraska, the average radon level is about 6, Iowa 8.5, and in North Dakota we average 7.4. However, certain regions of North Dakota, such as in Grand Forks, where Dave and I are at the University of North Dakota, 90% of homes in Grand Forks test above the EPA's threshold of 4 picocuries per liter, and 10% of homes have it above 20 picocuries per liter, which we'll note what that health hazard implies in the next few slides. So in this slide, you see that if your home tests around 4 picocuries per liter, it's the equivalent of about 200 chest x-rays per year or 8 cigarettes per day. Then going on to 8 is about 400 x-rays, and 20 is around 1,000 x-rays a year, or smoking 40 cigarettes per day. So why is radon dangerous? It's responsible for about 21,000 lung cancer deaths per year, or 58 deaths per day. Most people don't realize that radon causes more deaths than drunk driving. So here we see the lifetime risk of developing lung cancer. For those people who have never smoked and you're in the 20 picocuries per liter, it's about 36 out of 1,000 who develop lung cancer. But if you smoke, it's around 26 out of 100, so it increases substantially if you smoke as well. So, and the reason for that is that the radon actually attaches to the smoke particles, and then you inhale them and they enter into your lungs.
So Dr. Young, can I ask you a quick question?
Yes.
So since we talked about the radon levels in the upper Midwest are generally high, and we have some mean average scores of what has been tested in homes and neighborhoods or areas of North Dakota, if I had a test level of 8, does it mean my neighbor would also have a test level of 8?
Not necessarily. It just depends on, the geography and, where exactly your home is built. Whether you're on top of a bed of uranium or not.
My understanding is that's pretty variable and would also depend on the condition of and how and all of these other variables.
Right, exactly.
So it's really a home independent and individual environment dependent exposure.
Yes.
And then accentuated by the tobacco use, by the smoking.
Yes, I often joke about, that was one of the benefits of buying an older home being, built in the 1900s, they're generally not well insulated. So if you have a leaky house, you have less of risk of, trapping radon gas within it. But these newer homes, that are well insulated, they don't allow much air exchange. So radon not only is a concern in terms of developing lung cancer, but there are other conditions that some researchers here at the University of North Dakota, in particular Dr. Schwartz, who is an epidemiologist and who I believe is also participating in this webinar, has published a paper demonstrating higher rates of CLL, which is chronic lymphocytic
leukemia.
Thank you, I can't say that. And in North Dakota, higher rates than many of the other states, and that's very well correlated with the levels of radon. So here's some artwork. One of the ways that the EPA has been encouraging communities to get the word out is to actually teach the young folks about radon in their health education courses, such as in whatever chapters when they focus on environmental health issues, including carbon monoxide, poisoning, etc., is to teach them about radon. And so here's some artwork from some kids who were focused on that particular chapter. So how do you test for radon? There are two types of test kits. One's a short term, one's a long term. The short term, you leave in your house for about 48 hours. And you want to test it, place this test kit in the lowest living area. So if you have a finished basement, that's where it needs to be. Or if you have an unfinished basement and you rarely go down there other than for storage, then you want to put it in the first level of your home. So if you do confirm that there are high radon levels within your home, you should probably test for that again after that short-term test has confirmed that. And you also it's best to test during the winter. Here in the Midwest, the month of Radon Awareness Month is January, when our homes are pretty much closed up and heated, where furnaces are on. And then you should consider remediation if your levels come back over 4 picocuries per liter. So what do these radon remediation systems look like? Well, you start with it's more or less a PVC pipe that runs from underneath the floor of your basement or your lowest living space and runs up through the house, and then there's a little fan that's drawing the air up through that PVC pipe and then is expelling it out above the roof line. And these test kits or these remediation systems are, a few slides down, we'll talk more about how much they cost, but somewhere in the realm of $1,000 to $2,000, as opposed to if they're put in at the time of construction, that's maybe a couple $100 for the PVC and the fan. Some more artwork. Keep your radar out for radon. So our community has been engaged in a grant opportunity that was funded through the Robert Wood Johnson Foundation. It was called the Invest Health Initiative. And our Grand Forks Invest Health team was one of 50 teams selected nationwide to address this pressing public health issue, which in our case is radon gas. So we have a team of local and community stakeholders who are working to raise awareness associated with radon gas coming into our homes. Our team consisted of a number of people throughout the community, including people from the city administrator, a community development specialist, the CDBG, or the block grant coordinator, people from the council, the city council, as well as planning and zoning. We had folks from the Department of Health, in particular the Environmental Health Group. We had the chairman for the Chamber of the Government Affairs Committee. And then we had a number of people from the school system, the assistant superintendent of teaching and learning, some school board members, the health teachers. And then in the rest of the community, we engaged the Realtors Association, the Forks Builders Association. And then eventually we came across and figured out that there is a group in town. These are more grassroots initiatives called the Red River Valley Community Action Group, and they are charged with assisting low-income homeowners with all types of remodeling or housing activities around keeping their housing warm, or their houses warm in the winter, and all the way to controlling rodents. But in this situation, we called upon them to ask for their assistance in helping low-income households remediate once they tested. So we ran a little pilot project with them, and they tested a group of 10 homes, and they all came out testing above the threshold. And so they are still in the process of helping those homeowners remediate. And then last but not least, we had myself and Dr. Schwartz and Dr. Schmitz, who are faculty within the School of Medicine and Health Sciences, as part of this team. So most states have laws requiring testing and disclosure of radon in real estate transactions, but North Dakota does not. And it seems as though disclosing radon levels are pretty inconsistent with a seller's obligation to disclose any known hazards. So for example, Dr. Schwartz has talked about, if you have a big sinkhole in your basement, you need to disclose that as a hazard. But when it comes to radon, you have a radioactive mine in your house that it's not required.
Or lead paint might be another example.
Yes.
Of disclosure.
Right. So what our team was embarking on was trying to put together some legislation matching the states that surround us. And so there are two pieces to this legislation. The first was implementing a radon awareness law that provides information about the risks of radon. So basically in a real estate transaction, this requires the realtors to hand out a sheet saying, hey, you're moving into the area, you need to be aware that radon is an issue here and you should test your homes. So we currently do not have this awareness, but we're hoping to pass it in the next legislative session. We did introduce it in 2017, and our legislature meets every 2 years. So we almost had it. We were almost successful, but we're going to have to try again in 2019. So our public health goal with this was to increase awareness of this invisible but remediable health threat. And it's really the simplest, least burdensome way to accomplish this is to require this disclosure in real estate transactions. So it's pretty effective that when somebody moves into the area, that they're typically going to buy a home. And so they would be required, or the realtors would be required to give them this basically information that this area has a high risk. So the cost of radon remediation, if necessary, it varies, but somewhere between $1,000 to $2,000 for existing homes. I think I mentioned that if you were able to do this at the time that your house was built, it would cost far less, about 10% of that. And if levels of radon are detected, then a lot of times these contracts will provide, the real estate contracts will provide for splitting the cost of remediation between the buyer and the seller. Our second piece of legislation had to do with the new construction. So we wanted to update the state's building codes and require all new residential construction that they use radon-resistant construction practices. So installing these mitigation systems at the time that the home is built is generally much more cost-effective than remediating existing structures. So we have two options: the passive venting systems where a fan can be added, and that was what we had illustrated in a former or previous slide, or you can install a depressurizing system with the fan installed in the attic. So again, it's relatively inexpensive to implement radon-resistant construction practices. And in exchange for a few $100s in upfront construction costs, preventing even one cancer diagnosis could save society $30,000 to $50,000 in healthcare costs. So given that we can't see, taste, or smell this gas, and that all counties in North Dakota have homes testing above this action level, it seems that in implementing this new construction legislation is a relatively simple and ethical solution to alleviating this public health threat. So there's a new project that we are hoping to implement and would love to have the participants' feedbacks and thoughts as to how best to go about putting this intervention in place, and that is to promote integrating behavioral health change tools within the primary care setting. So it would involve multidisciplinary teams where we would pull together social workers and members of the community, including the action groups, and have the primary care providers actually ask patients during their wellness exams, have you ever tested your home for radon? And we do know that in particular, primary care providers are able to really motivate people to address lifestyle issues such as smoking, drinking, and weight loss. And so, if the person says that they're not tested or they tested, then the next question, of course, would be, have you remediated? And if not, there are often financial or logistical barriers to remediation. So then we would try to work with the primary care provider so that they're knowledgeable as to what resources patients would have in their communities in terms of social workers or community action groups, potentially, who they could be engaged or they could engage in providing assistance in terms of testing their homes, finding certified remediators, coordinating the project, and then financing the remediation expenses. And it's interesting because we don't really have a good handle on how pervasive these community action groups are throughout the state. We know that Grand Forks and the city of Fargo have community action groups. I did recently learn that the community action group in Fargo had disbanded. And so that, is somewhat concerning as to, well, which groups, who's out there that could put, potentially low-income households could lean on in terms of offering them assistance to test and remediate their homes.
And so, as you might be wondering, Minnesota does have large open rural areas. And so the other, I think, interesting perspective that we're coming at this from, not only in cities like Fargo, but is that we have large expanses of rural areas where, again, some of these issues, how to address them. So for example, finding a certified remediator that is able to come to a remote part of North Dakota may be a different issue than it is if you're living right in Fargo. So also working with primary care providers in a rural primary care setting is something I think we're adept to be able to learn from here in the state of North Dakota. So I was excited to get involved in the project, and I can remember as a younger faculty teaching family medicine in a residency program talking about radon, but frankly it was pretty brief. And then I moved to North Dakota, and I didn't really think about this odorless, colorless gas my own self. So I think that it's very interesting to be able to be part of this project as just one example of how we can engage both our learners and those that are doing research or instructing around rural primary care. And so a few thoughts about teaching the teachers, I suppose. This is faculty development and also engaging our learners as this project moves forward at our university and perhaps community efforts at your own institutions, is to think about how can primary care providers also be educated and really have effective education and impact with our patients. As Dr. Yonk was mentioning, we know that we can have an impact with regard to tobacco use and smoking in our patients, simply asking a question like, have you considered stopping smoking? And when I see the children's drawings, it reminds me of other efforts around drinking and driving and tobacco, where we also see that children are being introduced at an early age to express themselves around these dangers, but just radon deaths in proportion to drinking and driving is just substantial about how important that this is, at least in our area of the country. So in educating providers, one of the questions I think we've had is, how aware are providers of this issue and how is that being integrated into their practice? And so there are opportunities for both professional development, I believe, within our own department here, within our own state of providers, and also possibly continuing medical education related to that. And how would that affect or impact the behavior of the provider in the care setting of our patients and neighbors? Additionally, when we look at educating patients within the exam room, what are those most effective ways of doing that? how do we affect behaviors and the ways people are thinking about this, especially again, because it's such a covert, I think, thing to think about, and perhaps they're thinking about the $2,000 it's going to cost them and how tough it is to get it done, especially if it's the middle of winter and they're worrying about their heat bills, you know, just looking at these sorts of things. So when we look at primary care in the intersection with public health, which is really one of our points today, using this as one example, it is going to involve partnerships with epidemiologists, with population health, working with our public health sector, and also the providers being tuned into and able to capitalize on those resources in your own area and state. I also think it is an interesting question of how to create community awareness, specifically in rural environments, and create actionable plans that communities can self-actuate where they want to be with regard to leadership, as well as providing overall advocacy on some of the health concerns, as you've mentioned. And then finally, some of my thoughts to kick off our discussion was to talk about the role of primary care, and particularly rural primary care, for community health and for our patients, because we do talk about rural community context and how to be effective, in addition to working with community health workers, especially in population-based healthcare delivery systems, and also our other colleagues such as social workers, realizing that not every community has every resource, particularly in rural resource-limited environments. When we coordinate care, however, and we consider these social determinants of health, I really do think there is a new focus or a capacity to look at these sorts of issues around the social determinants, whether that be through patient-centered medical homes and neighborhoods, or other models that are going to be more driven toward looking at population health, not just one patient at a time. It's an interesting quandary, because we want to address population health, but no two neighbors may have the same radon testing score. And that really hit home with me, because it's not like something that just be applied at large to the community, and all of our patients will be addressing this from a different needs aspect. And so engaging learners is really what this is about, and how we can also engage our instructors affecting learners for rural primary care service. Dr. Yonk has provided resources that I'll have here for just a moment while we transition, Dr. Longnecker, back to yourself for ongoing discussion around, and suggestions, really, so how we can carry this project forward. And you may have similar public health aspects that you're working with your learners. And I'll turn it back to you, Dr. Longnecker.
I've got it. All right. Thank you very much for that presentation. And what I'd like to do now is to introduce Dr. Davis Patterson, who's a researcher and project director for Rural Prep, as well as deputy director of the WWAMI Rural Health Research Center from the University of Washington. Dr. Patterson, I'd like you to begin the discussion.
Me, okay?
Yep.
Okay, great. Well, thank you, Dave and Yvonne. Hi, Yvonne, for laying out not only the problem, but also potential solutions. And I especially appreciate the focus about primary care, which is what we're all about. But obviously, the interventions have to go way beyond just primary care. I guess one question that I had, and so, you know, I live in Seattle, and I noticed that Seattle was yellow on the map, was the light yellow. And so I know I've seen on, you know, real estate documents or renters documents, I've seen reference to radon around here, but it's not really something that's been much on my radar. And I was very struck by the mortality rates and comparisons that you showed. But I just wondered, what is your sense of how aware people are about this, particularly in the area that you live in the communities that you know? It seems like something that should be on people's radar, and I'm just wondering if it is, and if not, why not?
So can you hear me? Yep.
Yeah.
Okay. So, people aren't generally aware. They might be, it's not like they've never heard of radon, but it falls off their radar mostly because, it's clear, right?
The problem is clear.
The problem is clear. They cannot smell it, and so it's easy to just write it off and say, and also because the risk of developing cancer is years down the road. Like you cannot actually, there are no symptoms in the meantime. There's no evidence until you're actually, down with a chronic illness, and more than likely you will die from it. And so
I think that's a really good point. Let's just compare it to like a roach infestation. And if there was a child with asthma in a housing situation that had some roaches there, but if you saw a roach, it might upset you, and it's there, and it bugs you, right? And so, and then your child's wheezing more. I think one of the things about radon is that you feel really good about yourself that your house is all buttoned up tight when it's literally sometimes 10 or 20 degrees below zero, and you don't feel sick, and you've lived there for years and you've never gotten sick so far, and you might not get sick. But I do think that is something that is harder for people, both because of the length time with regard to the potential outcomes, the absence of symptoms, and the absence of being able to detect it without a detector.
But this also brings about, the importance of actually passing this legislation. Is that, if people, it's just like with something, seatbelts or wearing bike helmets. People may not think that it's important, but if you require it and say, you need to be, wearing your seatbelt, it's the law, then that changes people's behavior. Right now, we don't have anything on the books, in terms of even raising awareness about it. And so we're hoping that's why we brought it back around to the primary care setting, hoping that if your physician or your doctor tells you, okay, now maybe people will pay attention.
So as Dr. Jank is thinking like a population health person, I'm thinking like a primary care provider and saying to myself, so if a patient comes into the urgent care, they're not going to come in with a radon-associated symptom, unless unfortunately they've developed lung cancer, perhaps. Or is it going to be on my list of the 2 things or 3 things that quality indicators are going to say whether I'm a quality primary care provider in a rural setting? Maybe if we align that with community health needs assessments and an awareness of population and public health, for North Dakota, we'd get a golden star or whatever it is as a good provider, because one of the 5 questions we not only asked about was, do you drink and drive? But we also asked a very dangerous, a question about a very dangerous situation, which is, have you not tested your house for radon? But I think another aspect is, how do we provide the resources if they say yes, or if they have a problem?
So the other thing that Dr. Schwartz and I had talked about, who is our cancer epidemiologist, just this morning even, we had a conversation about, hey, people are required to have smoke detectors, for example, and carbon monoxide detectors in their homes, almost in every bedroom. Why not require eventually in this area, some kind of radon detection device, or, something that will monitor your air quality? They're fairly expensive at this point, but, if we actually pass this legislation, well, maybe the price would eventually go down, because, we'd have to, supply and demand, right? So just a few thoughts.
Yeah. All right. Well, thank you. And I should say to all of our participants that we have plenty of time here. I have another question or 2, but if you have questions, please use the chat box, and we would love to hear your thoughts and your questions as well for our panelists. Talking about primary care, and I appreciated your comments toward the end there about addressing social determinants of health and environmental causes that are related to health in primary care. And there's an increasing emphasis on that in primary care and in healthcare generally. I think we're trying to look beyond healthcare, but also to sort of integrate more public health approaches. And it just makes me wonder. I think the screening that you described, it's interesting, and it makes me wonder how will providers integrate that in terms of, is that the acceptability to providers of adding yet another screen and of all the possible screens that could be done. And of course, I think your comments too about sort of being aware of what a particular community needs based on the community risks is an important part of that, of deciding, what providers should be asking about. But anyway, I just wondered if you had any further thoughts about that, integrating, here's another screen, how can we support providers to do that? And also, if, what's the follow-up there? So if a patient says, okay, I'm going to do this screen, and they get the results, and then what? What's the next step? And how do we support both the patient and the provider in taking action?
Thanks, Davis. Well, I'll start with the first half of the question, which is trying to think about adding this to our workflow in primary care. And then I'd like to have Dr. Young comment about implementation of the services it would take to support a patient's vision for better health or better safety. And then I think we also need to realize that that's different in Grand Forks than it does in a community of 2,000 that's a couple hours from here. Because North Dakota is not only rural, but remote. That from a provider standpoint, you're right. I think there's a transition around looking at primary care being responsible, and I think appropriately so, caring for our patients around not only their sick care, but their preventative and well care, their health care. And I do think that there are a variety of number of opportunities to do that. And in fact, as I was suggesting, the quality indicators associated with providing that care can be attuned. And I know that we're working with those measurements of what good care is, what the standard of care is, even from different contexts, including a rural context. But every day we prioritize with our patients. I'll even say that we negotiate priorities with our patients because there's a certain amount of time and a certain amount of effort. Patients have come to what they're looking for, or what they have an impression that they're looking for, whether that be a medication or symptom relief, or someone to listen who can help them in the healing process or the coping process with illness. And I think as physicians, we come into the room as well with a agenda based on our impression of what the diagnosis might be, and whether or not it's related to also keeping people healthy in the future. So I think that as we look, that's why I brought up the patient-centered medical home and population health models, because I do believe that as we look at delivery of care not being only that interaction between the patient and the rural primary care provider, whether that be a physician or other primary care provider, physician assistants, nurse practitioner, etc. Hopefully we're actually building a patient-centered medical home, in which case we're not only receiving one aspect of care that individual day, but a wraparound package of services that would allow us to address everything from seatbelt use to radon. And so I think that it'll be very interesting to see what healthcare values, what patients value, and the providers' attitudes towards that. I do believe projects like this will have an impact on that. Frankly, I do think it matters, and public awareness of the problem. And in this case, again, the problem is clear. I like that, because this is such a great example. Symptomless, long time lag, serious consequences, real economic consequences, real health economic consequences, geographically targeted ability to make a difference. But once we get that patient, provider, and patient dyad from pre-contemplative to contemplative, maybe I'll do this. And then they make the decision, I'm going to do this. I'm going to quit smoking, doctor, and I'm going to test for radon. I'd love to hear that. All right, Dr. Young, where do I go from there?
Well, it's one thing to motivate the patient, though, to actually test their home. But once they have tested, or let's say you hand out free test kits, which we have in North Dakota. The Grand Forks Public Health Department hands out free test kits, and you can email, the state health department, and they'll send you one. But then, as the literature will point out, only about 50% of folks even, it's not a high percentage of folks will even send it back in. And then once they send it back in, then it tapers off. And so then they get the results. And then what percent of them actually remediate? It's not high, because they start to go, oh yeah, I know I have to do that. I will after I don't know, get my tax refund. And then, they decided, oh, no. I have other things to spend this money on. And it just becomes, again, it's one of those things that if it's not tangible right here, now and today, like if you have a leaky faucet, you need to fix it. But anyway, it's something that can be put off, and then it ends up not getting done. And so it's a real problem. So motivate these people and support them to actually get the job done is really tough. Not only is it, here in Grand Forks, North Dakota, let's say you've decided, okay, I'm going to remediate. The list of certified remediators is coming out of Bismarck. You can look it up, online. But they're mostly coming out of Fargo. We have one here in Grand Forks, one set of contractors, or a team of people who will do it. But that it's concerning because the more you move out into rural North Dakota, who are they going to call?
And to give you guys some perspective, I know traffic in North Dakota isn't the same as Seattle, Davis, but Fargo's about an hour and a half from Grand Forks, and Bismarck's about 5 hours, and that's if it's not snowing or that's at 70 miles an hour. So wearing your seatbelt, by the way, not smoking. So my point is that I think that these challenges are real. So unless your chat box is lighting up, I've got a question for our participants, which is. What advice do you have for us, if this is all right, around how would we engage our rural primary care provider learners to say, how do we address these problems? I think part of what we're trying to do is say, how do we train the next generation of primary care rural providers to be able to be effective in educating ourselves, providers, effective in the exam room with our patients, effective in the community, having an impact around what is for us a really serious health concern.
So as we wait to hear in the chat box from the audience, I have a thought about that. Dave and my personal story is very similar, are a testament to the fact that a single public service announcement or a 1-hour webinar by Dave and Yvonne is not going to probably do it. For students. And so what are the ways that we can actively engage them in remediating the problem, but also learning about it more themselves? We're not getting answers from the audience, so.
Well, I'll throw out one, which was, I think we could survey providers before and after an intervention to see what they're doing about the radon issue. Are they doing anything? Or is it just one of those things that we learned about in residency and might be one board question, at least for those of us who are family actors. I remember that it has something to do with rocks in Montana. That's what I remember from residency. Be careful of rocks in Montana. And it causes lung cancer. But I think, again, there's a big difference between that knowledge and saying, wow, this in this part of the country that I'm now a physician in, really need to be tuned into this, and I need to have this be a significant part of my health care plan for my population. And in another part of the country, also, if we have participants from another part of the country, can you think of what it is in your part of the country that maybe I don't need to worry about as much here in North Dakota? Unfortunately, I need to worry about sunburn and frostbite. But maybe there's other parts of the country that you don't really have to worry about frostbite so much. So it's interesting to think about radon because it's such a dramatic example of really being a hidden health concern that we should be learning how to address.
So,
Yeah.
so before I make a suggestion, what are you doing at the University of North Dakota?
Well, right now, we're working on passing this legislation at the state level, but we have locally had made a difference in terms of local building codes. So we were able to convince the building community that, okay, we need to add this to our set of inspections and make sure that any home that's constructed, that they're going to include radon-resistant new construction. So basically, ready. To remediate as necessary. And given that 90% of homes require, remediation, I think it was a step in the right direction. We're still working with trying to make a difference, right through the Red River Valley, because that seems to be a corridor of homes that test really high. The rest of the state is also high, as we know, but we're sort of taking baby steps, and working, because you have to start with the community. If you don't have the resources, within the community, such as, we were able to identify the community action group. I didn't even know what an action group was when I started this project, so there's a learning curve with this. And so once we have figured that out as to what resources are in the community, and what political will there is to move the needle and encourage, homeowners to remediate, I think that was our starting point.
So what are you doing with your medical students to lead them along that learning curve is what I'm trying to get at.
Okay.
And so with regard to learners, I think the first thing to do is to I'd like to begin with residents who are interacting with patient panels and in their community around assessing their prioritization of radon versus other aspects of care they're providing. I think that's the place to start, but we are initiating that work because we've just actually completed my familiarization and onboarding with the project. And so I'm open to the best research questions out there. I think there's scholarly activity for our faculty, frankly. I think there's maybe even opportunity for small research projects for our students and residents, again, at multiple levels, both involving provider awareness, attitudes and actions, patient engagement, community engagement. That's what I was looking for, a little bit of feedback around your fresh best ideas during this webinar.
I know
there is a, I just wanted to there is a comment, not in the chat box, but there's a Q&A, and I just wanted to read it out from Wanda, and I'm sorry I can't pronounce her name without you pronouncing it for me, but she says, as a public health agency, we found it is difficult for providers to change practice due to their electronic health records. There's a cost to adding screening questions onto the system. And so it comes down to the priorities as they have limited funding to make changes. We experienced this issue as we tried to get the AAR questions on regarding tobacco use. And I had thought about the EHR as well as a potential barrier in practice to including this information and tracking it.
I think that's a good point. However, it's not stopped providers. I'll give you another example. One of the things that we've identified, which I think is also aligned with the social determinants of health, is food security. And so we've actually had providers in some residency programs, for example, ask about food security over, let's say, a 3-month block of time with their patients and write a prescription with regard to, actually write a physical paper prescription. Doctors still do that once in a while. With regard to recommendations and work with social workers or other folks who are able to empower patients. I think we could roll out something like that on Radon. I think it would be interesting for students and residents, but students in particular, to work with MPH students to look at the community health need assessment for that town, especially in rural. I like rural because it's often geographically isolated information. You can map it. Where does radon pop up on the community health needs assessment in a particular town, or is it something that we can have students engage both in the care delivery services and public health services work together to ask some of these research questions I sound like an academic now, but also make a difference, and use best practices to affect change. You're muted, Randy.
Oh.
There you
go. We have a comment from the audience, and it aligns somewhat with what I was thinking, and that is, how about we work with students to achieve a systemic answer rather than a doctor-patient answer, and that is work for tax deductibility for radon mediation. We could get students.
And that goes along with the comment in the chat box too about getting a grassroots campaign on Twitter and Facebook about tax deductibility.
Yeah, that's where I saw it, and I thank you, Jeff, for bringing that up. I do think we have to get our students to think about system interventions rather than one-on-one interventions. They're both important, but I jotted a whole list of things down that we might consider doing. You have a distributed medical school system there in North Dakota, and so your students could function as mavens in their preceptors' offices, as well as in local health departments across the state. They could develop teaching aids or participate in community education in those communities. They could become hotspotters and go with a social worker to a home that has been identified. They could implement things in the provider's reception area that would promote radon testing. And not only radon testing, but testing in a way that got the reports sent back to the primary care physician. That would really be helpful.
Yeah, I think I really like what you ended on there, Randy, because it is about the learners who are often intermittent in the community, empowering that local community, including their provider, with a durable connection to the community. And that, in my mind, is distributed community engagement. So I appreciate that final comment particularly.
Any other comments from the audience?
I do have one. I have one question, and I know the focus has been on homes, and I wondered about workplaces and what the risks are. We spend a lot of our time, our lives at work, and so I wondered if you could comment on that.
So I do know that there, at least in this area, the schools have been tested, as well as people who, again, much more of a grassroots effort here, but people who are aware of it and are working in situations where they're in a low, that if they proactively test their workspace and show that, hey, this is a health hazard, and raise a flag about it, then something happens. That they will be able to either change offices or not, work in that location. But there hasn't been sort of a structured, systematic approach to the workplace in terms of testing that I'm aware of, at least not since this project. Since we've embarked on this RWJ Invest project, that has not come up.
It sure would be interesting to, in a given state, work with the hospital association, check the basements of the hospitals where probably the laundry's done and other things. I don't know, it just came to my mind for a moment, but there's a lot of different opportunities probably to lead the way to better health.
I mean, we don't even have legislation in place, to raise awareness when someone moves into the area, much less to take a systematic approach to testing public spaces. Now,
well, thank you all so much for presenting today and for our webinar participants' participation. I did want to save a little time here at the end to talk about our upcoming webinar. We have one next month, again, June 28th, 1 o'clock Eastern Time. Dr. Bill Phillips from the University of Washington will be talking about learner-centered research mentoring. And so this will be especially useful to those of us who mentor students and residents and other learners in research. We also will be releasing next week our call for proposals for micro research, which we've described previously. Please let us know if you would like to be notified, and we'll make sure that you're on our mailing list. And then finally, here is the link to the evaluation for this webinar today. You can either type this into your browser, or I think JP may be adding this in the chat box so that you can click on it there. And we really appreciate your feedback, not only regarding this particular session, but on how we've been conducting these webinars. We'd really appreciate that. Thank you very much for participating today. And I've given you our contact information there. We will be publishing these slides and recording of this webinar shortly on our website at ruralprep.org. And these contact details will be available there. Any last comments from any of the participants or any of the presenters, I should say?
Randy, excuse me, this is JP. There's another question here from the chat box from Jeff.
Okay. Is there a way the state can make it easier to become a certified remediator, create some jobs, and possibly drive down the cost of installation? That's excellent. Is there anything along those lines?
You know, we actually thought about this as a community development item, and you know, we have, I think, some HVAC services around, and we'll see. I do think, especially as we see potentially with construction codes, there's still a lot of building going on and remediation. There could be, I like the economic development angle when it goes along with better health. So thank you for the suggestion. And thank you overall to all of you for participating. And Dr. Young, it's been a good hour.
Thank you. I really enjoyed it.
Well, thank you. And you all have a good rest of the week.